Good afternoon, and thank you for joining our panel. I'm Dr. Sahira Long. I'm a pediatrician and medical director for the Children's National Anacostia Facility, and also a member of the Mayor's Lactation Commission, a lactation consultant, and a wife and mother of two. Before we get started, I'd like to thank the organizers of this summit for inviting our panel to participate, our panelists for agreeing to participate, and the board of the DC Breastfeeding Coalition that I'm president of that helped us to organize the panel, and especially Aubrey Villalobos, who helped us prepare everything for today. So before we get started, I'm gonna invite our panelists to introduce themselves, and then we'll jump right in. So Dr. Asiodu, can you introduce yourself, please?
Hi, good morning or good afternoon, depending on where you are today. My name is Dr. Ifeyinwa Asiodu. I am an assistant professor at UCSF, the University of California, San Francisco, and I am happy to be here with you all today and just want to thank the DC Breastfeeding Coalition for the invitation. Thank you.
Thank you. And Dr. Bugg? You're muted.
Good afternoon, good morning. I'm Dr. Kimmery Bug with Reaching Our Sisters Everywhere, Rose. We are located in the Atlanta, Georgia area. We are a national organization that was designed to address breastfeeding disparities in the African American community. And I am also grateful for the opportunity to be here and share with you today.
Thank you. And Ms. Henderson.
Good morning, good afternoon. My name is Chrisonne Henderson. I am a certified lactation counselor and work as a breastfeeding peer counselor at Children's WIC in Washington, D.C. And I also thank you for the invitation to be here today.
Thank you. All right, so before we start, none of our panelists has anything, unfortunately, financial to disclose, and we will not be discussing anything unapproved. I think we're all biased in our passion for breastfeeding, which is the topic of this panel. So as a pediatrician, I can't do a set of slides without objectives. So this is what we hope that you will take away from this presentation today. And I'm gonna start this off with a story just so we can center this discussion and understand why it's important. So this is based on a true story. And I want you to meet TK, who is a 32-year-old first-time mom, first-time pregnant, married African-American female. She tested positive for COVID-19 upon arrival to the hospital for delivery. And at that point, she was told that her husband, who was in the car, could not stay with her as she gave birth to their first child in spite of having had a negative COVID-19 test and a few days prior to their arrival. Her birth plan for as few interventions as possible was switched to a plan that to receive an epidural after she found out she'd have to give birth alone. Mind you, her husband was in the car outside the hospital. The epidural further slowed down her contractions, and ultimately she delivered by C-section. So TK gave birth, and after doing so, she was allowed to hold her daughter skin to skin and then given two options. She could either keep her daughter with her, and her daughter would stay in the room with her the whole time she was in the hospital, but she should keep the baby 6 feet away at all times and shouldn't hold her unless she was breastfeeding, after wiping her chest down and washing her hands. And the other option was to let the hospital team take the baby to the nursery, and she wouldn't see her again until it was time for discharge. So think of that story as we dive in. So we, at the Children's National Anacostia site, I serve as the medical director for our lactation support center. And TK's mom, so not TK herself, but the grandmom of the baby with whom I work, reached out to see if our team could help her with breastfeeding, because after 24 hours of life, mom still had not seen a lactation consultant, even though she'd asked to see one. And then on the last morning prior to her being discharged from the hospital, she was offered a telehealth lactation consult by one of the inpatient lactation consultants at the hospital, since they weren't seeing COVID-19 positive moms. So think about that as your first experience with breastfeeding as we dive into our presentation. So first, I'm going to start off with some basic information, and then I'm going to invite our panelists to join with some questions. So first, why does this even matter? So this is information based on a meta-analysis done by the Association for Healthcare Research and Quality. And what they showed pretty clearly is there's definitely a risk for not breastfeeding. So the greatest risk, of course, are for children and infants, which, this is a maternal and infant health summit. So we know that that's why it's important for this summit. But for our babies, we're seeing an excessive risk of 257% for hospitalizations in the first year of life for babies who weren't breastfed. And in case you thought breastfeeding was only good for the mom, the risks listed on the bottom are the risks that are excessive for mothers that don't breastfeed. So moms who don't breastfeed have a higher chance of developing maternal ovarian cancer and also breast cancer. And there's also cardiovascular risks that are higher for moms who don't breastfeed. So Lancet put out a series of breastfeeding journal articles a few years back and showed that we could, with optimal breastfeeding, we could prevent 20,000 breast cancer deaths worldwide. So what exactly is optimal breastfeeding? The two sources of, somebody said they can't see slides. Two sources of information for what we consider optimal breastfeeding are the World Health Organization, which recommends breastfeeding continue until exclusively for the first 6 months and then continue until at least 2 years of life. And then the American Academy of Pediatrics sets their own recommendations, which agree that moms should breastfeed for at least the first 6 months exclusively and continue to breastfeed for at least 12 months or as long as is mutually desired by the mom and the baby. So based on these recommendations, the U.S. Surgeon General's developed goals for breastfeeding. So Healthy People 2030 goals came out in August, and the two goals for breastfeeding that were set were, one, to increase the proportion of infants who were breastfed exclusively through 6 months of age, and to increase the proportion of infants who were breastfed at all through the first year of life. And you can see, based on the baseline from 2015 births, that we have quite a ways to go to reach our 2030 targets. And how did we do for reaching the 2020 target? So this is a slide that just shows how the United States did compared to DC, compared to the Healthy People 2020 targets. And this is data from the Centers for Disease Control and Prevention National Immunization Survey. And you can see for DC and the United States, we looked pretty good with quite a few of these breastfeeding behaviors. The goal that we did not meet was breastfeeding up until a year. So we're doing okay as a nation and DC as a whole with reaching any breastfeeding goals and exclusive breastfeeding goals until you look at duration. And on the outside, that looks really good. But if you break it down and look at how we're doing as a nation by race, this slide shows that there are huge disparities and if you dig really deep, you can see that the only two races and ethnicities that did not meet any of the Healthy People 2020 goals were non-Hispanic Blacks and non-Hispanic Native Americans and American Indians and Alaska Natives. And the moms who did meet Healthy People 2020 goals meet all of the Healthy People 2020 goals were non-Hispanic white and non-Hispanic Asians. All right, and so that was the DC, that was the nation. So how does DC stack up? Unfortunately, the CDC does not put out rates by race on an annual basis. So the most recent information we have is based on 2009 to 2011 births. That's the last time we had a cohort done on breastfeeding race by race. And you can see DC looks a lot like the nation. There's a difference between who's actually meeting the goals in DC. So even though we look like we're meeting it on a whole, if you break it down, there's really a tale of 2 or 3 cities here. And so I'm gonna switch gears really quick and talk a bit about what breastfeeding recommendations look like during the COVID-19 pandemic. So the 3 major health organizations put out recommendations starting back in March as we were trying to figure out what was happening with the COVID-19 pandemic. And from the beginning, the World Health Organization has pretty much stayed consistent with their guidance. The recommendations that the World Health Organization puts out for the world, so for the global community, is that mothers with suspected or confirmed COVID-19 should not be separated from their infants. And if they are suspected to have or confirmed to have COVID-19, they should still be encouraged to initiate and continue breastfeeding, because from what we know, mothers that should be counseled that the benefits of breastfeeding substantially outweigh the risk of possible transmission. And so they do recommend that a mom that is confirmed or suspected to have COVID-19 take a few precautions when they're breastfeeding. So they recommend that nothing change in terms of early skin to skin and contact between the mom and the baby as soon as possible after birth. If the baby is ill, the baby needs to have arrangements to stay safe in the neonatal intensive care unit, and the mom should be allowed to have free access to the unit with appropriate infection control precautions. If mom desires to breastfeed, the mom should perform frequent hand hygiene with soap and water or an alcohol-based hand rub, especially before contact with her child. If she's having respiratory symptoms, she should sneeze or cough into a tissue and immediately dispose of it, and then perform hand hygiene and wear a medical mask until symptoms resolve or she's no longer considered under the need to be isolated. If she's been coughing on her chest, she should clean her chest with soap and water before breastfeeding. But if she has not been doing this, there's no need for her to wash her breast prior to every breastfeeding session. So the CDC, as of September 4th, agreed that the ideal setting for the care of a healthy term newborn is within the mother's room. So separation is not a requirement. Temporary separation should be considered to reduce spread to the infant, and the risks and benefits of temporary separation should be discussed with the mother and her healthcare team. Any decision made should be respectful of the mother's wishes, and if she does choose to perform temporary separation, she should be encouraged to express breast milk, and a healthy caregiver who is not at high risk for severe illness should bottle feed the newborn the expressed breast milk. If she does not choose to separate, then she should take precautions, just like the World Health Organization recommended, to avoid spreading the virus to the newborn, including washing her hands, wearing a mask, and when she's within 6 feet of the baby, and as much as possible, maintaining a physical separation from the baby when she's not feeding. This information is taken straight from the CDC's website, so I'm not going to belabor the point, but these are this is the guidance that moms who are interested in breastfeeding would see if they went to CDC and pulled it up. And then the last source of recommendations is the American Academy of Pediatrics, who pretty much when the pandemic started, there was no information upon which to base recommendations. So all of these organizations did the best they could with the available information and have continued to update the recommendations as more information becomes available. So this information that I'm displaying right now is updated as of July 22nd, which, the pandemic started in March. So this is the third iteration of guidance from the American Academy of Pediatrics. And it's pretty much now aligned with the recommendations from CDC and the World Health Organization. The AAP strongly supports breastfeeding as the best choice of infant feeding. There have been several studies that are really small that have detected nucleic acid in the breast milk of COVID-19 positive moms. But what we don't know is whether or not that virus is actually infectious or if the mom is providing protection against the baby getting COVID like she does with a lot of other viral infections. Given all this information, there's no reason that mothers should not be counseled to breastfeed, and they should do exactly what the CDC recommends: perform hand hygiene before breastfeeding and wear a mask during feeding. All right, so with that said, I'm gonna jump into a few questions for Dr. Asiodu. And so Dr. Asiodu, can you share with us information about the impact of systemic racism, looking at the breastfeeding rates by race across the United States? Can you share with us some information about how systemic racism and institutional racism have played a role in these disparities and any policy or system solutions that we know work?
There we go. Hello, everyone. Thank you so much, Dr. Long, for your presentation and for a very critical and important question. So I'm, again, very appreciative of the DC Breastfeeding Coalition for the invitation to discuss racism, bias, and breastfeeding, chest feeding, and donor human milk with you all today. And so let's dive right in. Next slide, please. So before I get started, I wanted to acknowledge that I am coming to you all from the Bay Area and really wanted to acknowledge the Bay Area's indigenous peoples and communities and let you know that I'm presenting from stolen land of the Ohlone tribe here in the Bay Area. Next slide, please. And in regard to objectives, I definitely want to talk with you all in regard to the significance of systemic racism and bias as it pertains to breastfeeding, chest feeding, and the use of donor human milk, in addition to policies and system solutions and resources. And then, of course, happy to answer any questions that you all may have. Next slide, please. So I have 15 minutes with you all today. So if you don't take anything away from our time together, I would love for you to take away these 3 key points from my presentation: that racism and bias are major barriers to Black families reaching their infant feeding goals. And again, that can be breastfeeding, chest feeding, and the use of donor human milk, but also milk sharing and also supplementation and formula use and things of that nature. I also want you to know that Black women and birthing people do breastfeed, chest feed, and use donor human milk. And also that policies and systems solutions, such as Baby-Friendly Hospital Initiative, are key to improving infant feeding disparities and inequities. And so you'll hear me go back and forth in regard to using infant feeding, versus breastfeeding, chest feeding, the use of donor human milk. Infant feeding is a more inclusive term because I know, and we all know that every family, every individual may have different infant feeding goals. And so, but primarily I'm going to be speaking about breastfeeding and the use of donor human milk for this presentation. Next slide, please. So when we're talking about racism, specifically, we're talking about the systemic, institutional, and structural type of racism. We're talking about the discriminatory policies and practices, whether they're informal or formal, that are embedded in our everyday work, embedded in our systems. We're talking about the macro level system, social forces, institutions, ideologies, and processes that interact with one another to really generate and reinforce inequities among racial and ethnic groups. And these definitions can be found in Dr. Kimarie Jones, the Gardner's Tale paper. And I think it's also important to note, as Dr. Long presented, the different disparities and inequities that we see in breastfeeding that have been noted for over 40 years since we've been capturing data, that the disparities do not occur in a vacuum, right? We have to acknowledge and identify the systemic barriers and challenges preventing individuals and families from meeting their breastfeeding goals, especially given that if we look at breastfeeding intention rates, we see that Black women, we see that Indigenous folks, we see that Black Indigenous people of color want to breastfeed. They want to be able to provide human milk for their infants. But we have to think more critically in regard to what systemic structural barriers are impacting the way in which individuals and families can actually operationalize those goals. Next slide, please. So again, while we know that there are lower breastfeeding rates in Black and Indigenous communities, we also know that Black women and birthing people want to breastfeed. So when we're thinking about these disparities, we also have to note that there are barriers as it pertains to who receives breastfeeding education and resources. We know, unfortunately, that Black women are less likely, I should take that back. We know that in-hospital healthcare providers are less likely to discuss breastfeeding options and services with Black women. And we know that maternity care practices that are supportive of breastfeeding are limited in communities with higher Black populations. We also know from a study conducted by Dr. McKinney and her colleagues in Chicago that Black infants were 9 times more likely to be offered formula immediately after birth. And another study conducted by Dr. Sergeson and her colleagues at the California Perinatal Quality Care Collaborative at Stanford noted that infants in the NICU receive desperate care and were less likely to have access to donor human milk. And so we cannot say or continue to discuss inequities and disparities without context. And we can't use race as the reason why, or the issue or the response or the answer to why these barriers exist. We know that these disparities and inequities exist because of racism, because of bias. Race, it isn't that race or because someone self-identifies as Black, that puts them at greater risk for poor access to services and care and desperate care and things of that nature. It's the lifelong exposure to racism that impacts one's ability to meet their infant feeding goals, that impacts their ability to have positive perinatal health outcomes, both for the birthing person and infant. So that's something that we really need to shift in terms of our narrative. Next slide, please. And I'm just going to shift gears a bit. Next slide. To touch on the policies and system solutions in regard to, so we know that these disparities and inequities exist. What can we do? First and foremost, we need to listen to Black women and birthing people, right? We need to understand their lived experiences. And when folks are reaching out for assistance or help or support or resources, we need to be open to hearing thoughts, hearing requests, but also providing the necessary education and resources that are needed. We need to engage in racism and bias training. And I know that this is a touchy topic right now, especially if you work in government, whether that's at a federal level, at a state level. So I have a lot more thoughts on that, but I will just say that in order to address the inequities and disparities that are impacting our Black, Indigenous people of color, we have to talk head on about the racist policies and practices that are impacting their healthcare, that are impacting their quality of life and the quality of care being received. And we also need to talk about the importance of diversifying healthcare, the healthcare workforce. And specifically here, as we're talking about breastfeeding and lactation, we know that the IBCLC, when we think about the breastfeeding and lactation workforce, we often think about IBCLC's International Board Certified Lactation Consultants. However, we know that those who self-identify as Black, Indigenous people of color experience great barriers to achieving that certification, and that we see more diversity as it pertains to our breastfeeding peer counselors, our certified lactation educators and counselors. And so we really need to take a step back and address what are some of those systemic barriers and policies and practices that are impacting the trajectory of lactation support persons in achieving the IBCLC certification. In regard to other ways in which we can address infant feeding disparities and inequities is really utilizing evidence-based practices and policies, and specifically thinking about the Baby-Friendly Hospital Initiative, which I'll talk about in a few minutes in more detail, but also the importance of peer-to-peer support and really investing in community-led initiatives. And when I think about peer-to-peer support, I think about WIC and breastfeeding peer counselors, but I also think of organizations such as ROSE. And we're really fortunate to have Dr. Bugg on this panel today, who's the CEO of ROSE, to talk more about the work that they're doing to increase peer-to-peer support, and really are leading really amazing community-led initiatives. Next slide, please. So I wanted to talk just a little bit in regard to the Baby-Friendly Hospital Initiative. For those of you who may not know, it's a global effort geared towards improving the role of maternity care services that enable birthing and lactating individuals to breastfeed or chest feed. It really aims at improving access to maternity care practices that are supportive of breastfeeding and is in accordance with the International Code for Marketing Breast Milk and Substitutes. Every hospital that obtains the baby-friendly designation moves that much closer to meeting important public health goals and increasing the proportion of live births that occur in facilities that are really supportive of this public health initiative in terms of breastfeeding. We know that it isn't, when folks usually think about baby-friendly, they think about that it's more of a local initiative, or it's a local practice, and really it's a global initiative that was created by the World Health Organization and UNICEF in 1999. And it's a really broad scale implementation of 10 steps to successful breastfeeding. And I'll go over quickly those 10 steps. Next slide, please. And so these are the 10 steps, and I won't go over each of the 10 steps, but there's a essential group of different policies and practices that are incorporated within a hospital's culture and practice. The Baby-Friendly Hospital Initiative isn't only about practice change, it's really about culture change as well, where you have to have a policy. There's staff training and education and competencies that need to occur. We can only think about breastfeeding support and resources as it pertains to the postpartum unit and after someone gives birth. We really need to think about what type of education and resources are being provided during the pregnancy. And then also when someone is in our hospital setting, what type of resources and supports are we providing during labor or after they give birth Are we providing immediate skin-to-skin, barring any medical complications or any issues? Are we providing lactation support and care and resources? As Dr. Long presented in her case study, the patient in question didn't have access to a lactation consultant or someone to really assist in providing lactation support in the early hours and days after giving birth. And we know how critical that is. Do we have connections to community-based resources and supports? We know that individuals, barring again any type of medical complications, will spend only a few days in the hospital laboring and giving birth, but they will spend majority of their time within their communities. And so really thinking about how are we providing information and resources to really sustain breastfeeding and chest feeding or the use of donor human milk after someone is discharged. Next slide, please. The Baby-Friendly Hospital Initiative, it's a pathway which hospitals and health systems engage in over a period of years. This isn't something that can happen overnight. It takes a great deal of time, investment in resources, collaboration of not only in-hospital, but outpatient and community-based organizations to really come together to ensure that a hospital is designated baby-friendly. And it's a very rigorous process, and the designation is good for 5 years with the redesignation process afterwards. Next slide, please. So again, just thinking about why baby-friendly, we know that hospitals play a really critical role as it pertains to breastfeeding and chest feeding initiation, duration, and exclusivity. We know that evidence-based maternity policies and practices supportive of breastfeeding really impact the initiation, duration, and exclusivity rates that Dr. Long shared in her opening slides. And there's also data that shows that baby-friendly hospital designation really improves exclusive breastfeeding rates. And we see that extensively as it pertains to hospitals and communities, regardless of race, ethnicity, and socioeconomic status. And so if we're really thinking about policies and practices to address racism and bias and to improve disparities and inequities, Baby-Friendly Hospital is definitely, will definitely help lead us in the right direction. Next slide, please. So I just really quickly in my last few minutes with you all wanted to share just the impact of Baby-Friendly here in California. Next slide, please. In addition to knowing the importance and significance of baby-friendly, here in California, we took it a step further. Following the 2011 Surgeon General's call to action, one of the recommendations in that call to action was the acceleration implementation of baby-friendly in the United States. In 2013, Senate Bill 402 was proposed and signed into law here in California that all birthing hospitals and birth centers needed to adopt the baby-friendly 10 steps or an equivalent practice, which we call the model hospital policies, by 2025. And so we are all in as it pertains to really wanting to provide the most evidence-based maternity care practice, knowing the impact for both the birthing person and the infant across their life course. Next slide, please. As you can see over time, the proportion of infants born in baby-friendly hospitals has risen in California from 14% in 2010 to approximately 45% in 2018. Next slide. And something that I had asked my colleagues at the state in the California Department of Public Health, a maternal, child, and adolescent health branch to look at as it pertains to our data is really wanting to see what impact had our efforts in regard to baby-friendly designation, what kind of impact has that had on our disparities or inequities in regard to where individuals giving birth. And so as you can see from this data that was pulled in 2017, 2018, we definitely need to run a new analysis. We see that Black women are more likely now to give birth in baby-friendly hospitals in California. That wasn't the case at the beginning of our work. We were seeing baby-friendly being implemented in more affluent communities and hospitals and health systems. However, with a concerted effort and a collective push led by the California Breastfeeding Coalition, in addition to our collaborators in WIC and our local breastfeeding coalitions, we've definitely seen improvements in who has access to baby-friendly hospitals. Next slide, please. We also have eliminated the gap between individuals and families on Medi-Cal, and for those of you outside of California, Medicaid, and those who have employer-based insurance. Again, thinking through inequities and thinking through where baby-friendly hospitals were first being implemented, this is a real significance for us because that shows that regardless of insurer type, that birthing people and families will have access to baby-friendly hospitals, policies and practices going forward. And I will say, though, that just because an institution or hospital is baby-friendly designated does not necessarily mean that there still isn't work to be done, right? There's still definitely work that has to happen on a continuous basis to address anti-racism and biased practices. Next slide. And as you can see, we know that not all women and birthing people in California have equal access to maternity care practices that are supportive of breastfeeding. So even though while California has the highest number of baby-friendly hospitals in the US, we know that we still have a great deal of work to do, as you can see with the geographical gaps in regard to where baby-friendly hospitals are located. Next slide. And so I just want to share a few resources with you all in regard to the Baby-Friendly Hospital Initiative. In the United States, Baby-Friendly USA is the designating organization here in the US. So if you have any questions or thinking about your hospital or birth center or thinking about going baby-friendly, definitely check out the Baby-Friendly USA website. And I also just wanted to lift up different organizations across the country that are doing amazing work as it pertains to supporting, promoting, and raising awareness around the importance of the Baby-Friendly Hospital Initiative. We have Rose, who works in collaboration with CHAMPS. We have the Carolina Global Breastfeeding Initiative based out of UNC, and also the California Breastfeeding Coalition, which I'm the immediate past board chair of. Baby-Friendly Hospital Initiative was a huge priority for us and continues to be going forward. So if you have any questions or are looking for resources for your communities, definitely check out these organizations. Next slide. So then, and last, there are definitely other ways in where you can identify community resources, specifically around state, local breastfeeding coalitions, cultural coalitions, definitely your local hospitals and clinics and professional organizations as well. Next slide. And this is a quote from the Baby-Friendly USA website, which I absolutely love. And it reads, "Baby-friendly designation is hard for a reason. It's hard to ensure that mothers and babies all over the country receive the highest standards of infant feeding care in the precious first days of the child's life." And if we're really wanting to think about health equity, breastfeeding equity, ultimately eliminating health disparities and inequities, we really need to be thinking about ways in which we're providing the highest standards, evidence-based practices that will impact maternal and infant health across the life course. And last slide. Again, my key points. We know that racism and bias are major barriers to Black families reaching their infant feeding goals. We know that Black women and birthing people want and do breastfeed, chest feed, and use donor human milk. And we know that there are policies and practices and system solutions, such as the Baby-Friendly Hospital Initiative, that can be used and utilized to really improve key, not only infant feeding disparities, but also maternal health disparities, such as maternal mortality and morbidity as well. And then the last slide is just thank you for this opportunity. And feel free to email me if you have additional questions, or check out my research lab's website for more information about the work that we do. Thank you so much.
Thank you, Dr. Asiodu. We're going to save all questions that have come in so far until the end of the presentation, and hopefully we'll have time for them at the end. So I hope you can stay on in case there are questions for you. All right, so now I'm going to invite Dr. Bugg to share a little bit of information about how we in the healthcare and community can help support people of color to reach their breastfeeding goals. And if you're muted,
thank you all. Just want to say that more than most women and birthing people in the United States breastfeed their babies. We've, for the first time, reached the Healthy People 2020 goal of more than 81% of the nation's birthing people and mothers breastfeeding. So we are excited about that. Next slide. However, the disparities are here, and the gap has been so, as everyone has already mentioned, since we started taking statistics. So we want to make sure our goal right now is to close that gap. And next slide, please. We've talked quite a bit about COVID, which is extremely important in these days right now. And I'm going to talk a little more about it in telehealth because we've had that covered very well. Next slide. Uprisings that are going on in the country are another issue right now that is deterring and causing a cause of some moms not being able to reach their breastfeeding goals. We need to know, and you know, it's been pretty apparent in these days that racism makes us sick. There are things that we can do to address this, and so there have been some phenomenal programs and projects that are going on due to COVID, due to the uprising, that have truly helped to address these concerns in breastfeeding. Next slide. This is a hospital in the Atlanta area that is baby friendly. We are extremely excited to say that, but this was the day of white coats for Black Lives Matter. And these are medical schools from Emory University and Morehouse School of Medicine and Mercer School of Medicine, all pretty much together, stating that they truly understand and want to address these disparities. Next slide, please. So wanted to talk briefly about emergency preparedness, because here in the Georgia, Alabama, Louisiana areas, we are having tornadoes and hurricanes. And in California, they're having all of the fires. Climate change is real, and it's affecting a large majority of the country. And because of this, of course, we're having many concerns with breastfeeding also. So just a couple of things that we need to address to make sure that folks head to safety. Keep offering the breast. That's important. Learn how to hand express. Store milk if possible. Delay weaning. Milk sharing is a thing that is going on. We don't have time to talk about it now, but it is something that is definitely going on, and think positive. Next slide. So I want to just briefly talk about peers, partners, policies, and programs. And a lot of this has definitely been covered, and I'm happy about that. Next slide. So peers are phenomenal. They're really changing the landscape of breastfeeding. We need to assure that we have lactation support providers at every level in order to make sure that moms are able to reach their breastfeeding goals. It's phenomenal to have someone next door or down the street or at the local recreation center or your place of worship that can help young women with breastfeeding in the community, for us, by us. Next slide, please. Partners are very vital. Particularly Black men feel a lot of times that they're invisible in the entire process. We need to make sure that we address the partners, make sure that they are part of the process and have the opportunity to learn. We say a lot of times that our families are resource deprived. They have not been given the information and the resources to make informed choices. So that needs to be done for the mothers, for the fathers. Next slide, please. And also for grandmothers. Grandmothers are a needed resource for breastfeeding sustainability. And therefore, we need to assure that they are brought into the process when possible and are also given the resources. Next slide. So we've talked about the baby-friendly process, which has truly made an amazing difference in communities of color. It's not necessarily that all boats, the tide raises all the boats, because sometimes, folks don't have a boat, but policies definitely do change some behaviors. And we're happy that more and more hospitals are on the baby-friendly pathway. Next slide, please. So telehealth, this is something that I need to just share with you right now. There are some phenomenal programs going on. The CARES Act is funding telehealth projects through UNC Chapel Hill, which is one that Rose is involved with. And we are able to give funds to people throughout the 10 public health regions to address telehealth needs. Our funds, specifically Rose, are going specifically to support providers who are in the community. So doulas, midwives, lactation counselors, CLCs, and we are really happy that these funds will allow them to spend more time doing telehealth. And also we have funds for the communities to sort of address the digital divide. So look forward to sharing more information about that. Next slide. So the reality is some communities start in the hole. Some communities start at a place of privilege. And it is important that we address these concerns and make sure that the moms get the resources and information that they need to be successful with their breastfeeding goals. Next slide. Couple of references. And that is it.
Thank you, Dr. Bug. I had to unmute myself. As always, a pleasure hearing you. And I'm going to shift our conversation to the DC WIC program. And I have a question for you, Mrs. Henderson. So can you tell us how this COVID-19 pandemic has impacted WIC's ability to provide breastfeeding supportive services and what you all are able to do to support families that choose to breastfeed at this time?
Thank you, Dr. Long. Next slide. So because of COVID-19, it has made a significant impact on how we provide breastfeeding services. We've had to alter how we provide breastfeeding education and also breastfeeding support because we are not seeing our participants in person. So because of that, we are unable to provide one-on-one lactation support, offer hands-on breastfeeding assistance to our moms who may be having some difficulties with latching or positioning. We are unable to conduct in-person breastfeeding classes, and also we aren't able to lead in-person breastfeeding support groups. Next slide, please. But we have been able to provide remote services. So we have been able to have one-on-one lactation support. appointments and breastfeeding classes, support groups, all via Zoom. And in addition, we've actually been able to hold a breastfeeding event. As you all know, last month was National Breastfeeding Month. And so within my agency, we were actually able to hold 2 events, one highlighting National Breastfeeding Week and also Black Breastfeeding Week through Zoom. Through this, we've also been able to continue calling our participants, calling and following up through their pregnancy and also through their breastfeeding journey. We've been able to continue also offering BFED, which is a text messaging program that we offer to our participants, where the breastfeeding peer counselors are able to reach out to our participants, especially if we are unable to reach them by phone. But also this program provides general breastfeeding information to a participant during her pregnancy and also during her breastfeeding journey. And in addition, we also have a partnership with the Pacify app, which also gives our participants 24-hour access to breastfeeding support from a lactation consultant. And with this also being said, they're able to download this app for free because we're able to give them a special code to download it and sign up for free. Next slide, please. Also, we're able to give resources. And I just wanted to highlight 2 resources here. We have the USDA WIC breastfeeding support website. And the goal of this website is to equip WIC moms with information, resources, and to support them so they can be successful in their breastfeeding journey. One thing that I love about this website, which Dr. Bugg kind of spoke a bit on, is that they actually have a section just for grandparents and also fathers, and how they can support mom through her breastfeeding journey. Then also we have the DC WIC website here. This is another place where mom can find out what services we provide within WIC, or see a schedule when we have our support groups, depending on what agency the participant may go to. Then also we have a list of other organizations within the area that mom can be able to check out and see. Next slide. So just like I said, we've had to become creative with how we reach our moms during this time, since we are not seeing them in person. So one of those ways that we try to become creative and think outside the box is we went to our social media. We went to DC WIC's Instagram page. And so during the week of Black Breastfeeding Week, we highlighted our breastfeeding peer counselors. So each day a breastfeeding peer counselor was highlighted, and she was able to basically share a little bit about her breastfeeding story or experience, and also her experience as a breastfeeding peer counselor. We also were able to highlight the Million Milk March event that the DC Breastfeeding Coalition and BSARS that they hosted, and that they were graciously invited WIC WIC participants to join in for free to join the event. And one thing I did not put on the slide, but I also want to highlight one agency who actually highlighted their own participants on their actual Instagram page as well. Next slide, please. So with that all being said, and how we have changed how we reach our participants, and how we've been able to educate them with remote services and support them with remote services, we've actually seen an increase to our rates. Since the end of March, where we started remote services, we've seen an increase. And now these rates consist of our moms who are exclusively breastfeeding, who of course are not getting any formula from us, moms who are mostly breastfeeding, so moms who are mostly breastfeeding and receiving a little bit of formula from us, and then our moms who are partially breastfeeding, who may be doing half and half, or maybe doing a little bit more formula feeding than breastfeeding. And it's been amazing just to see our rates increase and see that what we're doing is working, because we all know how important we know how important what we are doing and how much it's needed. Next slide. Thank you.
Thank you, Mrs. Henderson. We have a few questions. I'm going to stop sharing slides and open up so we can answer some questions. And this was great. Dr. Asiodu, your presentation reminded me of all the work that we're doing in DC, trying to achieve what California's been doing. And I trust and believe that the work that we're doing will close those gaps. So there have been a few questions that have come in, and I'm going to take them in order. We have about 5 minutes before our panel ends. Anyone can answer any of the questions. So first is, are there general tips or guidance for how a mom can advocate in regards to breastfeeding, particularly in a hospital? And anyone can jump in. Go ahead, Dr. Bugg.
So yes, I'd like to say, first of all, they need to ask for some help. If their physician writes an order for them to be seen, it is more likely that they will. So and then ask everybody that comes in. The nurses are trained to manage normal lactation, and therefore they should have the skill to be able to help them. And then, just continue to ask for what they need. That is what is most important, is to verbalize and say, this is what I need. Everyone has the opportunity to evaluate the hospital and the staff. Everybody's looking for, those patient satisfaction surveys. So be sure to tell everyone that you plan to fill one out and then ask for what you need.
Thank you, Dr. Bugg. Anyone else have anything else to add?
I would echo that. And I think too, unfortunately, in the era of COVID, folks may not have a number of people in the hospital room with them. But if they are able to have a support person, that person as well can advocate and say, my partner, my daughter, my whomever needs support. And do that as well. And I think too, also thinking about before someone gets to the hospital, there's a lot of those type of questions in terms of what are the resources available at the hospital, who can I go to, things of that nature that folks can look into during their pregnancy, to some of that anticipatory guidance to better prepare for when they do get to the hospital setting.
Thank you. And I don't really have much to add to that wonderful answer. And in the interest of time, I'm going to skip to the next question. And this will be quick. I'll answer it. Is there evidence-based data to support the CDC's recommendation that encourages continued breastfeeding during the COVID-19 pandemic by race? So I'm not completely sure what that question is asking. Is there evidence base for the recommendation to continue breastfeeding? Absolutely. There's no evidence that the virus has been found in the milk to cause infection. The jury is still reaching verdicts on how protective it is, but like most other viruses, we think it's going to be the same. In terms of by race, the CDC collects data on births by race nationally every year, and it's usually released in August. So the data that I shared at the beginning of this talk was based on births from 2017. And so I'm not sure that we'll have data on births by race for this time until 3 years down the road. So it'll be interesting to see what happens with those rates as we get them. It's a retrospective survey that gets sent out after the babies reach the end of their breastfeeding experience. There's a specific question for Dr. Asiodu. Do you know specific examples of anti-racism and bias trainings that have had significant positive effects in the healthcare field? Well, we can't hear you. Maybe our time is up.
Sorry, hello?
Oh, yes, now we can hear you.
Okay, sorry about that. Dr. Joya Pericari's group with NBEC, they do amazing anti-racism and bias trainings nationally. The diversity group that was just recently started by Dr. Rachel Hardiman out of the University of Minnesota School of Public Health, they also host really amazing anti-bias and anti-racism training. Also Race Forward and the Center for Social Inclusion also have really amazing evidence-based type trainings and approaches that are available as well.
Thank you so much. And it looks like we're at time. So I want to again thank our panelists for this amazing talk, and again, our organizers for allowing us to share this information. There were a couple of questions that really one question that we didn't have time to get to, and we'll find out if there's a way to share that answer on the app.